So, good morning. I'm Dr. Francisca Belmar, and on behalf of the Simulation Center of the Catholic University of Chile, I will present you our work that's already been mentioned. We have to declare some conflicts of interest, and both Dr. Julian Varas and Dr. Gabriel Escalonas are members of Training Competence, which developed the platform C1 Do One that is going to be used in this study. First of all, it is important to remember how is medical specialty certification done both in the United States and in Chile. In the case of Chile, medical specialty certification is done immediately after one graduates a surgical program at a Chilean university, but it's required from immigrants that have done, or Chilean that have done the study abroad. In the case of the United States, this is mandatory for everyone. In both cases, we have a written or multiple choice evaluation, and after passing this evaluation, an oral exam is required. But what is missing in both of these evaluations is that we're leaving something very important that for surgeons in order to be proficient, is that we're not testing practical skills. So what our team did is that we developed an objective evaluation where we could measure technical skills using a digital platform with remote and asynchronous assessment. How did we do that? We used a previously validated objective structurized clinical examination, and across 2019 and 2020, we took 68 surgery applicants, and within 7 days, they were assessed through remote and asynchronous assessment using a platform called C1 Do One. All the procedures were recorded in high definition with 2 complementary angles. Each station lasted 20 minutes, and we have an extra 5 minutes for our technicians to do the setup. And the total time per OSCE was, in average, 200 minutes. It went from 180 to 240 minutes each. And the total assessment per evaluated surgeon was a total of 56 minutes. After the assessment was performed, all of our participants answered a survey about the evaluation. The stations we used at our OSCE were basic nuts and sutures, bowel anastomosis, ostomies, laparoscopies, both basic and advanced modules, vascular anastomosis, lung injury, heart injury, and we also had a rest station. In here we can see how our platform works. As you can tell, at no point we can see the surgeon's face. They are only identified by their number they have on their hand. As you can tell, here we have a surgeon C2A3 that is performing a penetrating heart injury repair. And on the downside of the video, you can tell that we have the OSAT's global rating scale. That is one of the methods we use for this assessment. In order to do this assessment more equal, since all of the procedures are very different one from another, we weigh them according to how important they are in surgical practice. The ones that weighed more were basic nuts and sutures, bowel anastomosis and ostomies. These were ×3 the score. The intermediate weighed laparoscopy and vascular anastomosis, and the ones that weighed less due to their lower frequency were heart injury and lung injury. To do a proper assessment, we decided to use different scales. The main scale used for assessment was the OSAT's global rating scale. This weighed at 60% of the evaluation. Then we had a specific rating scale for each procedure, and this weighed at 25%. And we also have a culmination and final product, and this weight is 7.5% each. In order to pass this assessment, a 75% total achievement was set up as a cutoff score. And where did our surgeons came from? It is important to highlight that an 85% of the surgeons that took this evaluation were from Venezuela. Most of them were 39 years old or less. And we also had a 25% of females that took this evaluation. How did they do on each station? Well, the station that had the best results was basic nuts and sutures, and the one that had the lower results was laparoscopy, although, as you can tell, laparoscopy has a wide dispersion on the results. And when it comes to how did they do in total, once we weigh in every station, well, most of our participants achieved higher than the cutoff score. Only 2 of the participants failed the evaluation, while the ones that pass go from 75% of achievement to a 90% of achievement. We also, as I previously mentioned, did a post-assessment service. This was a 5-point Likert scale that consisted of 7 questions that went from strongly disagree with the affirmation to strongly agree, in which we would like to highlight 2 of these questions. The first affirmation is, the procedures assessed were basic competences every surgeon should be able to perform, in which a 91.2 agreed or strongly agreed with the affirmation. And the simulation models in each station represent this procedure realistically, in which a 98.5 agreed or strongly agreed with the affirmation. But what are the good and the bad sides of the evaluation? The good side is that this is the first time in our country where we assess technical skills in surgery. We did a standardized and objective assessment. This allowed us to do a massive surgical certification in a brief period of time, and we were able to decrease the time needed for experts in these evaluations thanks to the remote and asynchronous system. What are the downsides of the evaluation is that we risk familiarity with the assessment. Since it's already standardized, the same station repeats one time after the other, and we risk the fact that they can train actually these stations. That's it. Thank you.